But welcome everyone. Tonight's really all about heel pain syndrome. And I've sort of put, when it's more than just plantar fasciitis. Of course, we're so used to seeing it always be more than just plantar fasciitis. And really, looking at it more from, okay, we don't talk about just heel pain and plantar fasciitis, we talk about heel pain syndrome. And for myself, as a few of you will know, that I've got this real focus on chronic pain because a lot of the patients that do see me are typically at the end of their sort of, life of seeing practitioners and like, okay, what do we do? And that's where we can use some of those advanced techniques. But really, I wanted to sort of take it back to basics, and I'm sorry, we'll go back to uni and sort of focus in a little bit more depth, and I hope you take a bit from that. I'm more than happy to take questions throughout, of course. You all know that I like being interrupted and going on tangents for hopefully not too many minutes. So let's see what we can do, what trouble we can get in, and go from there. So a little bit about me. I'll go through, I'm Dr. Kent Hungerford. I'm a specialist podiatric surgeon and podiatrist. Really what I do here is that chronic pain management using different injection techniques, not just steroid, but also, using our laser therapy and sort of advanced podiatry techniques, which we can all do. My other area when it comes to surgery though is that minimally invasive reconstructive foot surgery. So the bunions, the hammer toes, the corns, the callus, all those things that are really annoying for our patients I can typically get rid of through a minimal incision. And then, our high-risk foot, so our ulcer management, looking at that and really sort of pushing down to make sure that we're less likely to have patients that move to ulceration and amputation. And so really wanting to focus further into that in the coming years as well. For those that are unaware, the toilet bathroom is just down the corridor. It's got the sign on it. Feel free to knock or jump straight in. Food and drink, please jump up and get it. For those that are watching back, make sure you come next time if you can, take a flight. We do have the recording going so that those can watch us back, and we've already had a bit of a chat about me, so I think that's all we need to do. Really, there's quite a few things that we need to be going through today, and I think really that assessing, the diagnosing, managing that complex heel pain being a big part, and then a bit of what's next as well, so that we can see where I'm going and what we've got next week. Now, I'm not sure if anyone saw some of the QR codes on the wall there. Feel free to have a bit of a look at them, but next month I'll be talking a little bit more about toes. In particular corns and everything weird and wonderful about them, from ingrown toenails to hammer toes, to our subungual exostoses and anything arthritis there as well, right through breaks, fractures, etc. So hopefully nice and broad for all professions and everyone that comes along as well. So initially, let's have a little bit more of a chat, really about, okay, how are patients presenting? And yeah, this is where I am apologising because we'll go back to uni a little bit to get a bit more on that history of the complaint and the presentation. Do feel free to grab some drink and food and make yourself at home. So we all know this, and although I don't use PQRST as much as I actually think about this, does anyone use that strictly at all? I think we sort of gave that away in that first sort of week out of uni maybe. But it is a really nice way to sort of come back to, because we want to start thinking, okay, well, this is what's going to guide us and we're all going to have our set way that we go through. But really, we're talking about that provoked by, so what causes or increases the pain, that quality, so is it throbbing, dull, burning, stabbing, sharp, thick, numb, the pins and needles, those crawling like ant sensations that our patients sometimes say. And that gives us a little bit of an idea of, okay, well, which system are we talking, muscle, tendon, ligament, nerve in some of those cases. Where is it on the body, that region, but also thinking about the radiation. Where is it coming from? Where is it going to? The severity. And this is where I want you to start thinking, for those that were with us last month with regards to the biopsychosocial model of pain management, and thinking, okay, well, we talk about severity from that 1 to 10, you know, and how bad that is, but then let's break that down a little bit. Okay, so where's your pain at, but also where's that, you know, other side of the psychosocial coming into it? Because, you know, when we then push on them, we're like, well, it's not too painful, and when they walk, it's actually, you know, it's not looking like an 8 or 9 out of 10, but there's definitely that psychological impact of the pain being, you know, I now can't work, or I might not be able to work, I might not be able to feed my family, I might not be able to keep a roof over my head, over my family's head, and all that's going to definitely come into, no, I need this fixed right now, I'm 10 out of 10, you need to fix it, please. You know, there's so many things that rely on me. And so we need to be thinking about that severity in a little bit of a broader scope there as well. Because the stress definitely does come into it. But then we also think about time as well. You know, when did the pain start and how long does it last? Is it different times of the day? So, you know, thinking about the timing in that aspect. Do each of us sort of go through this, if not specifically? I imagine that's a very straightforward thing that we would all be going through, particularly in our musculoskeletal pain sort of consults. But then, you know, consider further what our patients have gone through. So interventions trialed so far. You know, what do you, you know, what worked, what didn't work? Why do you think that these worked? And, you know, I was just saying to my parents just before I came here, and she was saying, you know, one of her friends, you know, after 18 months, you know, of having heel pain, and she finally resolved, and she was like, you know, it was definitely the knee to wall and the sort of the heel raises, and, you know, in particular sort of dropping down. And I'm like, well, you know, after 18 months, it might have just resolved by itself, even though she's been doing these for 18 months. I don't think it was, you know, at that time that it sort of resolved from that. And so go, okay, well, I'm putting more sort of, yes, the patient thinks this has happened, and that's very important, don't get me wrong, but what aspects have we changed? So she also just changed her shoes as well. You know, it could be that just that little thing that put her over the edge, and now our threshold of pain, you know, is a lot higher, and we don't need to worry about it as much that way. But also then think, you know, our medical history, our medications, you know, that side of it, the allergies, and really thinking about what systems are these involved in. You know, we might think of our patients with diabetes, and, you know, we start to talk about endocrine conditions, you know, and thinking, okay, well, what else is this going to be affecting? Or our inflammatory conditions, our rheumatoid arthritis, our patients that say, oh, I've got psoriasis. You know, and we're thinking, okay, well, could this have crossed over into more of a psoriatic arthritis episode? You know, is there any gout? You know, yeah, I actually just stopped my allopurinol now. And we start to think, okay, well, yep, great. How long have they had these conditions? How have they been managing them now? But also, you know, how have they been managing them previously? And it does take a lot of time. You know, if we're new grads, I sort of look back now to myself as a new grad thinking, yeah, I got this. I know everything, and I look back now and think, gosh, I knew nothing. You know, another few years of uni will do that. And then also, you know, the different experiences that we gain have just been in the profession for a bit longer. But then also think about with those different medications that they might be having, and the different conditions that they might have, say for anxiety and depression. You know, there's potentially some crossover there. Let's take NDEP, for example, where we know that a nice low dose NDEP can very magically resolve a lot of our pain symptoms as well. You know, there's some of those things that they think, oh yeah, you know, and because of my pain, I've actually, you know, developed depression, and then, you know, I've been put on this medication, and it's really helped my mood and stabilized everything that way, but also my pain's been significantly relieved now because I don't have depression, and maybe that medication has that side effect of reducing the sensitivity of nerves. And so we need to be thinking that side as well from a pharmacological, you know, impact on what we're looking at. As well as polypharmacy, as well as, you know, they might have had some injury recently and they've been put on a type of antibiotic that might just happen to be detrimental to tendons. And so we have those great examples as well where you need to be thinking, okay, what's been happening more recently, and, you know, thinking more holistically that way, as I know we all do. But then we go into our previous surgeries, and we, you know, the classic patient, and I had one yesterday saying, you know, and I think it was the heel actually, you know, left heel pain following a right knee reconstruction. You know, everyone before has sort of said that he's got a leg length difference. I double checked that just in clinic, not through x-rays, and it looks pretty similar. So I'm not too necessarily worried by that. There's a little bit of bowing of the legs. There's a little bit going on there functionally, potentially. And, you know, we start to think, okay, well, yeah, there's maybe some stresses that are happening. But, you know, also think about that sort of, you know, that surgical iatrogenic cause there, you know, meaning from surgery. Scarring could be causing nerve entrapment, and I had a bit of a chat with some of the ladies earlier, you know, the pain, the sensitivity from these sort of things, that can be a really classic thing. And, you know, whilst I'm on that, you know, scarring for my patients is something that I, you know, see a bit of. And, you know, you can very easily help minimize that by using a silicone-based cream called Strataderm, which is about $30, $40, tiny little tube, but that tube should last you a good 60 plus days if you're using the tiniest little pinpoint of a head, and that's the pinhead, and that's something that you know, is a really good option for our patients. You know, great if they're compliant, but if they're not, they're still going to get some benefit. But with that post-surgical side, you know, we also talk about that pain sensitization, and, you know, we then start looking into, you know, this inflammatory sort of multitude of conditions where we start saying, okay, well, yeah, this patient, you know, does have fibromyalgia post-surgery. They've potentially got some other sort of abdominal pain. They've also got shoulder pain. All of a sudden you're going, okay, well, there's quite a few different pain aspects here, and, you know, we're looking at rheumatoid, fibromyalgia, and all of these sort of windows open. So making sure that, you know, if there is some central and peripheral sensitization, that we're very much aware of that, or at least exploring it as well. Now, I don't want to tell you, you know, I feel really awkward because, you know, some of the, you know, practitioners in the room are, you know, quite senior, well established, and, you know, you know what you're going through. You're doing this really carefully, and I wanted to sort of break down a little bit more about how I approach my assessments, and I hope you get at least one pearl of wisdom out of this. But I know that we're all in a very strong position where we're doing these quite thorough. But when we talk about heel pain and heel pain syndrome, and I did this only yesterday, is I took a step back. And this is sort of a surgical term that we use quite often when, you know, we're stressed, or we don't know what's going on, we're not sure what to do. You know, we look at our sort of assistant and we say, let's take a step back. And we'll literally step back, you know, in the theatre, we'll fold our arms because it's one of the only things we can do with our hands. And we'll just say, okay, let's just sit here for a moment. Let's think about, okay, where are we? Where have we come from? And what are our next options? Let's have a bit of a chat about that. Because when it all goes wrong or not according to plan, we need to be able to say, okay, well, yeah, you know, this has happened. That's really annoying. Let's let that frustration go. Great, okay, now where are we going to go from here? And sometimes with our patients, particularly with these chronic heel pain syndromes, it's about taking that reset and saying, okay, let's go back to the imaging. Let's have another look. Have we got all the imaging that we need? You know, what have we tried? What has worked? What hasn't worked? And just rediscussing that with our patient as sort of a step back exercise is really nice. You know, when we start talking about gait, you know, and we might do a full another assessment, and that's where I'm going to go through here. Because, you know, sometimes we do get busy and we do that 5-minute quick biomechanical and say, yep, cool, let's get these orthotics, yep, they're going to work, you know, let's implement this strengthening, let's do a bit of shockwave, laser, let's send you for a steroid injection, okay, go, I've got the next patient, thank you. And sometimes we can get caught in that, but when we step back and start thinking, okay, well, you know, let's have a bit of a look at some of these things that we're talking about. So we talk about the abductory twist, we talk about any instability through the ankle. In the case of yesterday, you know, the fifth ray was very hypermobile, and I'm like, well, I didn't totally appreciate that last time. Maybe the foot was more tense last time, as it was the first time they were seeing me. You know, that uncontrolled pronation, you know, stepping away from flat foot being a problem. I don't want that rapid pronation, you know, to be occurring, and how can we control that a little bit further? When we're looking at that standing assessment, you know, we're looking for symmetry, but is there a symmetry? What's the contralateral foot and leg doing? You know, same with the hip, you know, same with the shoulders. What are we looking at there? That foot position, that planus versus cavus, the resting calcaneal stance position versus that neutral calcaneal stance position. You know, how much navicular drop is there? Do we have a too many toes sign? You know, consider that windlass mechanism, which I, you know, will admit I get a bit lazy with the windlass mechanism quite often as doing it as a loaded exercise. But it's sort of a standpoint when I was going through uni of every patient must be checked for the windlass mechanism. our passive range of motion of the foot, that ankle and lower limbs, the knee to wall test. And when we start talking about, the knee to wall, and I mentioned that earlier, that clinical relevancy around it's quite interesting. And I did a bit of a literature review on this a few weeks back, because I was thinking, I personally don't find that my patients, that are significantly compliant with stretching have as good or have a different outcome to those that don't do any stretching. And looking at the evidence, that it is reasonably low level evidence saying that stretching is actually beneficial, and it's all around maintaining that that stretching exercises ongoing to ensure that patients get a longer term better outcome. Now that's sort of taken a turn, and there's quite variable evidence with regards to, some of the evidence does say stretching doesn't do squat. And we then start thinking, okay, well we're so, and through our uni, well mine at least, it was all, knee to wall, let's get stretching, let's get moving. And I talk about the seesaw a lot more now. And the seesaw is where we talk about strength and flexibility on the seesaw, and I want that seesaw balanced, but I probably want it about 10 stories off the ground. So let's do both of them, let's raise that patient up and really get the outcome that we're looking for there. And I think that brings us really well into, our strength-related assessments. That resistance, palpating along the tendon, looking for any tears or sensitivity at the insertions, along the muscles, looking at trigger points there as well. Are we doing any heel raises, our single leg stand? Maybe we're going to do and check some Trendelenburg as well. And we've got some great evidence, and this is the evidence that I always tell people, one that's come from our ballet dancers, from when I used to do pre-point assessments for our young teenagers, it feels like an age ago. But really, we talk about our pre-point dancers needing to be able to do 30 weighted standing heel raises, nice and slow, and then they can go on to the single heel raises, and be able to do 30 of those, and that gives them a 90% reduction in their risk of an ankle sprain compared to one of their co-parts that maybe haven't done that type of an exercise thing. And so our minimal aspect to get them onto point was to be able to do that 30 and then do 30 singles. Now that's a lot of strength that I definitely don't have, but very important when you're literally just on your toes. And so then I say, well, this is what I want you to work towards to my patients. Now I don't expect you to be able to go on point, but let's sort of push in that direction as well. And I think that's a really nice way to go. I don't get patients to do those single heel raises till they can do that 30 at least holding on of doubles. And that I think is a very important aspect in my practice. We then talk about our neural tests. We all do sort of a Tonell's, sort of a light percussion. We talked last time about sort of our Valix point assessments, and that's basically where our nerves are going to be bifurcating, coming out of fascial layers, going under them or crossing over. And that's sort of those areas of tenderness and could be indicating that there is a neural component to our pain. We talk about a 10 gram monofilament, our 128 hertz tuning fork, looking at those small nerves versus large nerves. We talk about our reflexes and our straight leg raise as well. But then in the end, definitely University of Western Australia, hammered into us, and I'm thinking of one of our previous professors, Laurie Foley here. He'd just come in and he'd just say palpate, palpate, palpate. Because that is, in the end, the best way that we're going to know location-wise as to where this concern is. But also think of our other tests when it comes to, squeeze tests for the calcaneus in this case. Start trialing our taping, our padding, in the assessment versus 24 to 48 hours afterwards. And we might be changing that. At 24 hours, I want you to take off this piece of tape and see if we have a bit of a difference and sort of work in that way. Now, I'm sure that a lot of that is what you're already doing, and so I apologise for putting a few of you to sleep that way, but I think it's really nice to recap these sort of things as well. We then look at some of our imaging that we undertake, whether it's ultrasound, X-ray, MRI, CT, our contrast MRI or CT, and a lot of these sort of things, some we are comfortable referring for, some we may never refer for. When it comes to contrast, I refer them back through to the GP a lot of the time for appropriateness, but I'm only really looking at contrast when it comes to sort of infection, and by then I'm sort of hugging my patient and getting the healthcare team to go around there. Thankfully, I've not been in that boat post-training. But, you know, all these sort of things we start talking about, you know, one of the biggest things in the heel is ultrasound's a great option. And it's a great option early on in particular, as well as chronic, but early on we do get that idea of if there is a periosteal reaction, for instance, then we're going to see bleeding from the bone. And, you know, when patients come in with, say, like that metatarsal stress reaction, I put the ultrasound on them. I don't do an x-ray because straight away I can go, yeah, actually I can see that bone callus there that's coming up, which we may not be able to see on the x-ray for maybe another 3-4 weeks. And so that's where it's like, great, you've done an injury last Friday, quick ultrasound, great, that bone's bleeding, it's actively bleeding, it's likely there's a stress reaction, let's go into a boot. And it gives that patient that very clear understanding. Now, we can't always do that in rooms, and so that's where referring for the most appropriate imaging is very important. Similar thing for, you know, x-rays, like great, they tell us what we're looking at, but then we see a heel spur and the patient only sees that, and then they think, of course, that's the problem, when we know very much it's not. Now, I'd always do an x-ray and ultrasound first, and if patients haven't had one, you know, in the last sort of 18 months, then I'm sort of like, yeah, we really need to do this. When I talk surgically, it's within the last 6 months, but then we move on to the MRI, and we do know that's going to be very sensitive. It's going to tell us everything that we want to know, but isn't always needed. Obviously, the costs around that, you know, privately for us referring anywhere between $250 to $350. If you're in Sydney, I've heard 900 quoted for a single foot MRI. That's a bit steep, not really a fan of that. But, you know, it's going to show different things. And then we move into our CT, looking more at our osseous concerns and getting a greater understanding of what's happening there. Now, what I did want to mention with regards to heel pain syndrome that I'm seeing a little bit more at the moment is some patients that are having sort of 3 monthly ultrasound repeats. You know, maybe 3 or 4 of them even by the time they get to me, and I'm like, cool, but like, how's your pain going? And they go, I've got no pain, but my ultrasound keeps saying that I've got really bad, you know, plantar fasciitis still. And I'm like, that's great, get out of the boot, let's keep moving. You're as right as rain. We now need to do a very intensive strengthening program. And so, you know, yeah, do think about getting another ultrasound, you know, if you feel that there may have been something missed, or, you know, particularly if we're not as comfortable with the length of the report or the images that we view. You know, having the art of being able to read images is a very important thing too. But, you know, if it's getting worse, staying the same, then do consider an MRI. And I say staying the same with regards to pain. If pain's trending down, you don't need any imaging, you just need more time. But, you know, if you do re-image, maybe consider looking at a larger segment. You know, could this be referring pain from the leg due to a bone tumor or something crazy? You know, could we be missing some adhesions to a nerve a little bit more proximal? How about we start bringing in other practitioners like the physio to exclude any lower back components? You know, maybe doing another one of those straight leg raise tests and seeing what's happening, if anything, in that aspect. But, you know, the other aspect would be if there's infection or concerns that way, really important as well to look. How are we going? Anyone want to take a break now? Because I think that's sort of the background sort of things that I wanted to get out of the way that I know that you all know really in depth as well. But let's start getting into, you know, some of the conditions that we're going to talk about, because I think, you know, having a bit of a chat about these ones in particular is really good. And in a moment, I'm going to scare you a little bit, and I apologize for that. But it's all going to be explained as we go through this evening. So we do talk about, you know, different aspects of plantar heel pain syndrome. They can be 1 or 2, they can be all of them at once, and we need to be able to differentiate between that. And that's what tonight's really about. Now, let's start with our neural origin. You know, thinking about Baxter's tarsal tunnel syndrome, thinking about that medial and lateral calcaneal nerve entrapment. You know, talk about our osseous concerns, you know, those calcaneal stress reactions, the fractures, potentially bone tumours, you know, the heel pad atrophy or fat pad atrophy, our plantar fasciitis, you know, whether that's a true mid-band or an insertional plantar fasciitis. You know, think about whether there's maybe some plantar fibromatosis. Really nice when we can feel them, but sometimes we need the ultrasound. But really, in my opinion, that true plantar heel pain syndrome does involve that mix of several of these, you know, and so we're going to go through so that we can start to differentiate those a little bit more and just give a bit of a refresher on that aspect too. Now, the common sites of tenderness here that we see for the heel pain, and they've got a few numbers there that I hope you can see from where you are. You know, our one really at that insertion of the calcaneus is that plantar fasciitis. Number two over here is really that entrapment of the first branch of the plantar nerve, or the lateral plantar nerve. We're talking about Baxter's. You know, that true isolated plantar fasciitis is actually sort of a mid-band, but then we very commonly see that fat pad atrophy, that fat pad inflammation as well. It's very rare, and I actually get excited with my patients. I say, I think you've only got plantar fasciitis. And they go, well, it's only really painful. And I go, yeah, I know, but this is great. This is something we can very quickly fix. Now, do you want to just be like, hit it with a sledgehammer and do a steroid now? Or do you want to do this more comprehensively and maybe a little bit less painfully? You know, having that chat with patients as well, I think is a really nice thing. And bringing them, you know, back down as, you know, this is okay. This is a very common condition that we see. This is the one that I said might scare you a little bit. Has anyone seen this before? Excellent, beautiful. So comes from some research, really looking at it in a little bit more depth. Now, I'm not going to go through all of this right now. I'm going to give you some time to digest it. But basically, we start at the top and ask, does this patient have heel pain? If it's no, we finish this lecture right now and we're all done. Great, thank you for coming. Take some more drinks and food and we're good. But if it's yes, then we need to start looking at where in the foot the pain is experienced, the heel broadly, more specifically potentially. And then we start saying, you know, can pain be reduced? And then we say, no, we're going straight down to potentially bone. But if we're saying yes, you know, what's the symptomatic structure? And then that's where I'm going to leave it at the moment, and we're going to come back to this. But when I first, you know, started looking at this lecture, I sort of reached out to one of my colleagues because I couldn't remember where this came from at the time. And I was like, you know, do I ask or do I just let sleeping giants sleep? But I think this is a great diagram in explaining it a little bit further and sort of going through these tests. So we're going to go through that in a little bit more depth today. But let's start with our nerve entrapments, because this is my favorite area, to be honest, because I feel everything is sensitized in some way by the nerves, and at very least the pain that we're experiencing or the nociception that we experience as pain is coming through from the nerves. So we know plantar heel pain has a neural origin with dysfunction of the tibial, plantar or calcaneal nerves, and 15 to 20% of neural heel pain is caused by Baxter's nerve. And so we need to always be remembering that. Now that's the, and then we've got the medial calcaneal nerve is one of those aspects too, but the nerves can really sustain trauma due to sort of that fat pad inflammation or the atrophy. And so we need to start thinking, okay, well, all these components are mixing together. What I also say to people is where we have fat, we have nerve, or where we have nerve, we have fat. And we need to be really mindful of that because, you know, all of a sudden when you start sort of feeling around some of the areas, whether it's on your hand as I am now or the foot, we start to think, okay, well, yeah, this is where our nerve pathways are. We need to start going, okay, well, yes, there's fat underneath the heel. There's also quite a lot of nerves there as well. And I won't scare you too much with this one just yet. Because that, as good as I can, and there's two nerves that are not quite 100%, is pretty much all of the nerves on the foot. In particular, don't look too much at the leg, but really we start to think, okay, well, yeah, there's quite a bit going on here, and we need to be really aware of where they're coming from and which branches of which nerve are we looking at, so we can treat that right up the foot and leg. Starting down the bottom, our medial calcaneal nerve, a little bit of lateral coming in the side. Then we go our tibial coming into our medial and our lateral plantar nerves. But then we've got a little bit of the saphenous nerve coming into that arch as well, and we can't forget that one, as I used to always forget it. But, you know, definitely something to be considering there. When we start to look a little bit more, and I'm going to talk a bit more about our Baxter's nerve in this area here, and I'm going to do my best having a bit of a look through here. So, you know, we're coming down on our tibial nerve. We've got that first branch of the lateral plantar nerve, which is where we then have our Baxter's nerve entrapment, whilst our medial calcaneal nerve comes across. Our lateral plantar nerve here is going to be starting to get entrapped by that abductor hallucis. In between that and our quadratus plantae are more deep compared to our flexor digitorum brevis more superficially, but then with our plantar fascia lying more superficial to that again. Now, all that Baxter's nerve wants to do is get past all these structures and over to our abductor digiti minimi, and so that it can innovate and provide the strength for that. And so when we look on an MRI, very commonly when they're looking for Baxter's nerve, we're not going to see it. It's such a small nerve. But when we then look at our abductor digiti minimi, we then start to see that there's atrophy of the muscle belly, and that's going to be our diagnostic aspect of what we're looking at for Baxter's nerve entrapment that's more chronic in nature. But it gives us a little bit of an idea, okay, well, yeah, let's do this anatomy refresh. Let's make sure that we've got that very clear in our head. What layers are we looking at? And it's not as simple as what we might be expecting. Having a little bit of a further look at our nerves, we can see that there's quite a few different areas that we can potentially get entrapment here. Again, our tibial nerve coming through, our flexor retinaculum, as we're bifurcating into our calcaneal nerve, the medial in this aspect, wrapping around our calcaneus and our medial and lateral plantar nerves, and then, feeding down into our toes eventually, we start to think, okay, well, there is quite a bit that can happen here. Our tarsal tunnel, for example, any space-occupying cysts, whether they're veins, lipomas, ganglions. One of my favourite tarsal tunnel decompressions was actually for a distally extending muscle belly of the flexor hallucis longus, and that muscle belly was extending right down into the tarsal tunnel, and we're thinking, well, no wonder this patient's having such significant pain. Unfortunately, those 3 mil cuts on an MRI, that it wasn't showing on the MRI because it pretty much lied straight in the one plane, and so that's where we go, okay, well, that was a poor miss on the MRI, which may not have been repeated. But still not responding to steroids, clinically had the diagnosis, exploratory surgery was very well worth it in those cases. Now, it's not a very common thing that we do, but there's these type of things that we do see more often than not. They're ganglions in that area, or varicosities, of course. Baxter's nerve is something that I think we all see really quite commonly, and we all know where to push, if I can get my foot, to really start to go, yeah, cool, this is where I'm looking at, this is what I'm seeing, just around that bifurcation, and as we're sort of seeing here, as it's coming down towards that deep abductor hallucis as well. As we know, we already know where all the nerves innervate to in the different areas, so I'm not going to go through that in too much depth. What I am going to go through in a little bit more depth is talking about some of those nerve entrapments, because really that location, as per our prior slide here, is going to be really important, and doing a little bit of a Tunnels along that is going to be great. Think about where the symptoms are coming from. Imaging's always really nice, but it's not always going to be very clear in telling us exactly what it is. And as we're coming through, yeah, are the tests positive? Are we reproducing some of those neural symptoms due to whatever we might be doing, or whether that's from a straight leg raise to our Tunnels percussion? A really nice one is using our tuning fork, because it's going to give that sort of irritation. But also, think about for our tibial nerve in particular, we're going to evert that foot, we're going to dorsiflex it and really stretch that tibial nerve. See if we get any burning pain. And I love burning because it's that very local nociceptive pain that we get, that we can pretty much say that burning is a localized sensation, or it's arising from a local area. So I'm pretty comfortable when I hear burning. I'm like, yeah, I can fix you because this is in my domain and only my domain. Okay, it's in the foot. Then start thinking, is there imaging required? Do we need to look at ultrasound, MRI? How sensitive are these for the area of impingement that we're looking at? Like I said, we're looking at the Baxter's by looking at the abductor digiti minimi. So, we need, and the ultrasonographers are very good at doing this, is making sure that we're getting appropriate imaging when we refer for the most appropriate, in the most appropriate way. So a really nice subjective history saying, query, Baxter's nerve entrapment. Imaging, great. Yep, If it comes back saying, yes, the imaging says there's something, great, we've got that plantar heel pain of neural origin. If there's no abnormality, then, you know, we start thinking, okay, is it maybe entrapment? Is it, you know, a radiculopathy, so something coming from more proximal? You know, we really don't necessarily know. And that's where it gets really tricky. So a lot of the time we are just diagnosing on our symptoms alone. When we start to talk about management of our nerve entrapments, we start to talk about, you know, all of our standard things, you know, our RISA, rest, ice compression, elevation, and our rehabilitation. You know, it's going to be quite similar to some of our other conditions that we would treat, in that, you know, we want to talk about rest, our non-steroidal anti-inflammatories. You know, consider our corticosteroid injections. And I put it to the patients pretty bluntly. I say, you know, this is, you know, a lot of people come to me and say, oh, isn't a steroid just a Band-Aid? I say it's a Band-Aid by itself, but, you know, you're going to be out of pain, and we need no pain to function, we need no pain to rehabilitate you. But, you know, we want to do that in combination with some of our standard therapies, whether that's just strengthening or orthotics or otherwise. You know, whether we're doing shockwave therapies, high-powered laser therapies, or PBMT, photobiomodulation therapy, our orthoses, our strapping, our stretching, you know, consider all of these options. For myself, I find the lift-docked prolotherapy, the 5% dextrose, is really effective, and that's something that constantly surprises me how effective it is. And so, you know, really that's a really good option. You know, or even nerve hydrodissection. So we're injecting potentially local anaesthetic with or without steroid along those nerve pathways to break down any adhesions to that area. But, you know, from our physio point of view, you know, consider flossing more proximally, where we're going to start really getting some stretch and mobilising those tissues around that nerve pathway. You know, I would suggest that's the less aggressive hydrodissection, you know, and is a quite effective option. But, you know, when we start to get to these options being exhausted, we then start talking surgically and decompression of those affected nerves. Now, Morton's neuroma aside, because definitely that's a part of what we're talking about here, it is very, very rare, to the point where I don't think I've done any other, you know, invasive nerve releases or decompressions more recently in the last 2-3 years, because our conservative work really, really well when we're targeting it very effectively, potentially in exhaustion of everything else, some of our injection therapies. And so do keep that in mind, particularly if some of our patients come through and we're like, you know, I've got non-neuroma or non-Morton's neuroma nerve entrapment. Most, if not all of those patients, 99%, are going to be going home pretty comfortable after 1 or more injections. It'd be a very rare day that we do need to go to surgical decompression. Now, Morton's neuroma is very different, and there's a few different ways we approach that, from excision through to a deep transverse metatarsal ligament transection or release. And something like that, it's only a 2mm incision and they're back in their normal shoes within a few days. And so, you know, that all of a sudden becomes a very different conversation as well. But again, we've already used steroid and exhausted some of those more conservative injections and other options as well. Let's move on to bone, shall we? Something that we all go, yeah, you know, we see a lot of this. It's very tricky because it takes so long to heal, and our patients always come to us with, you know, unrealistic expectations. And, you know, what I say to my patients typically is, you know, I'm going to get this better as quick as possible, and what I'm aiming for is a 50% decrease in pain within 4 weeks. And patients are like, oh, that sounds pretty good. You know, really, they came in aiming for 100% pretty much tomorrow. But at least we can bring it back and say, this is what I expect if we went sort of all in on sort of what we're looking at here. Because a lot of our patients come in this area, you know, where they can't weight bear. You know, we've got that clinical suspicion of bone concern, and then we start talking about, okay, do we need an X-ray? You know, do we need a CT? Is there a relevant or appropriateness for an MRI? You know, is there actually an abnormality on that imaging, or can we feel the abnormality because it's actually a fracture? You know, is it just a heel spur, in which case, you know, don't worry about a heel spur. Worry about the plantar fasciitis that's potentially attached. You know, but do consider it, of course. But really, you know, that's where we start then going, okay, well, are we talking fracture, periosteal reaction? Are we talking maybe something a bit more concerning in towards our tumours or our infections? You know, and one of the greatest things that you see on an x-ray that's commonly missed, particularly in the high-risk world, is, you know, that sort of gaseous or gas sort of area or collection relating to infection that can be missed quite easily. And, you know, all we're feeling is that it's really spongy and, you know, all of a sudden something erupts and, you know, that it's all going down and you don't want anything to do with this patient until they've got a lot of antibiotics on board. But, you know, these sort of things come up. You know, CT scans can be really useful in special circumstances like I'm talking about. But, you know, particularly things that mimic stress fractures, you know, such as osteomyelitis with an abscess, you know, those osteoid osteitis, and our other bone tumours where they might be seen there. You know, as soon as we see that sort of thing on an x-ray, you know, I don't do oncology, I don't do oncology podiatrics. I send them to the GP with a quick phone call saying, bit suspicious for, wouldn't mind if I can handball that out of the way at the moment to make sure that we have that patient surrounded more appropriately and quickly, more likely through the public system rather than in the private domain. But there's things that we can do to make sure that that patient's getting there quickly, which is most appropriate imaging. But when we start to talk about, you know, some of our symptoms as well, it's really that night pain that's more typical in bone, or at the end of the day, it's coming on more commonly the longer we're doing activity. You know, the location is more diffuse. You know, it could be quite broadly through that whole plantar heel. And, you know, that's where we start to think, okay, well, is it medial and lateral calcaneal nerve, or is it actually a little bit deeper? And having a bit of a look that way a bit more. Now, I mentioned this very quickly earlier, and I love this image because it's sort of showing, you know, one of our stress rises through the calcaneus here, and then what we're seeing on ultrasound. Now, we don't see an x-ray here because the x-ray is not showing anything yet. It's too early. And so we need to just be thinking, okay, well, if I am concerned that it could be a stress fracture or fracture, you know, maybe I send for an ultrasound just in case it's not actually coming up yet on the x-ray. And it's just a really nice way to be really holistic there. Again, we want to pick our patients and not overload our radiography and radiologist friends, but, you know, a really nice thing to be thinking about. Now, when we get into the management of calcaneal stress fractures, you know, we're really wanting to initially screen for how's that happened. Is it as simple as that patient has fallen out of a car or off a high wall, or is it that this patient's been running when they haven't really undertaken that strengthening workup to start with? You know, look at the type and intensity of that exercise, the running surface, whether it's on the road, the concrete, the grass, you know, changes in that training or equipment, brand new shoes bringing this on even though they're a marathon runner. You know, really those older shoes have lost their shock absorption. We need to be really mindful of that. But we want to assist healing with our rest and ice, and, you know, consider continuing that for up to 8 weeks. But you know, don't stop it, swap it. Let's get into the pool and do a few of our other activities. Let's focus on the upper body in the meantime. You know, but then let's start reintroducing exercise as we're coming down in pain, which means that, yes, we're going to have to be really aware that we want to build that strength back up again so we don't end up back where we are. But we can also provide pain relief and the ability to get into that through some of our strapping or accommodative insoles, or a short leg cast for a short period, say about 4 weeks. But really those, you know, when it's at its worst, we really want those non-weight bearing activities. We might be looking at crutches, one of our knee scooters, which I love, particularly after fusion procedures. But, you know, that again leads us in, you know, assess the risk of the non-union and potential surgical referral there as well. You know, the really tricky ones can be, you know, quite invasive procedures for the calcaneus. It's things that I've done in the past, but I don't currently do acute fractures of the calcaneus, mainly sort of those metatarsals forward. But, you know, these are the sort of things that we go look at, we go, great, yep, let's make sure that we get the right team around them if we think, and if you need an opinion, I'm more than happy to provide that. Questions with what we've covered with regards to the neural component or the osseous bony component? Fantastic. No one's fallen asleep yet, which is even better. No snores from the crowd is much preferred. So let's start talking about our typical plantar fasciitis. Our plantar fascia running from our plantar heel. And then we start thinking, okay, well, where are our insertions? You know, medial is quite medial. Our mid's really going down into our toes, and our lateral is coming onto our styloid process. And for whatever reason, more recently, I'm seeing a lot of lateral band plantar fasciopathy with maybe a little bit of, you know, peroneal brevis insertional tendinopathy at the same time. And it's really just this really swollen plantar to lateral proper styloid process that I'm thinking, well, you know, there's a lot going on there. We throw the ultrasound on, great, we've got some brevis insertional tendinopathy, but that plantar fascia of the lateral band is quite thickened and inflamed with or without some vascularity on ultrasound. So it's definitely something to be considering. Now, yeah, we always want to be looking at the systemic side, but with the plantar fascia, you know, an ultrasound is fantastic. It's definitely the starting point, but a lot of us are very comfortable with our palpation, and I definitely would say if you're palpating the plantar fascia, it's the only area that's painful, great, we've got plantar fasciitis. Let's manage it as that. We don't need an ultrasound, and we definitely don't need an x-ray to confirm that. If it doesn't get better, then let's go back up to step one and re-image. Or start those images. You know, consider whether we want to do some pathology, typically not required, particularly if it's responding, but you know, there could be some inflammation there on our ESR, our CRP, you know, that could be of, you know, very little or negligent aspects there, because we're looking at the whole body. If one area is stressed, I'm sure the whole body is going to be. But then we go, okay, imaging, do we have plantar heel pain? Is there a tear or rupture? Is there plantar fasciopathy, plantar fasciitis? Maybe there's some plantar fibromas of the mid portion of the plantar fascia. You know, all these sort of things that we want to be looking at. When we talk about that true plantar fasciitis, we're talking about along the band and, you know, trying to be aware not to be onto that peroneal longus insertion underneath sort of, you know, that plantar navicular and cuneiform area. You know, but we want to be right on the medial tubercle of the calcaneus for sort of our origin plantar fasciitis, which is what we're going to be more commonly seeing. You know, consider undertaking a weighted windlass mechanism and see your patient almost kick you. You know, all of these sort of options is what we're looking at. Now, if there's no swelling on ultrasound or physically seeing that swelling, then it's less likely that it's going to be plantar fasciitis, and that's where we start talking about our plantar fasciopathy or our plantar heel pain syndrome. Symptoms-wise, we know the classic symptoms. That post-static dyskinesia. Patient first steps of the morning goes, yeah, Al, that's not really fun. You know, it's typically going to be aching and throbbing, but can be sharp. And think about, okay, is there a tear there? And that tear's typically going to be that it's more towards that posterior plantar aspect of the heel, where that's going to be more painful. And so if they are getting that, you know, pain sort of further back here, start thinking, okay, could this be something more? You know, looking towards a tear, because that's where the nerves are going to start feeling that referred and irritated pain from. You know, looking at our imaging, our ultrasound, we know 3 millimeters pretty normal, a little bit more is okay. Once we're starting to get above 4 millimeters at the plantar fascial insertion, we're starting to diagnose plantar fasciitis. You know, x-ray may have you know, maybe a good thing for the exclusion of other concerns, talking more bony in that aspect, but really, you know, a heel spur, that's just because everything's really tight and that's going to be okay. My exception is when that plantar heel spur is pointing straight down or is fractured. That's usually, and I've only seen a couple of those, but that's usually when I'm thinking about sort of a surgical procedure in the, you know, after completing all of our conservative care unsuccessfully. Again, you know, we don't need to re-image every 3 months. If it's not responding by that time, then you need to up the ante and go for an MRI, but really patients should be responding reasonably quickly if we're providing them a really aggressive program of care. Now, the hard part there is when patients go, well, I don't have the money to do everything, then, you know, give them a paper tape, like a medical tape, and just say, you need to be pulling this up, you need to do even just a stirrup every day, and patients find that to be really effective. We talked last month about sort of, I use Hyperfix an incredible amount because it's flexible, it's stretchy. It acts like a ligament in that it's going to give our brain extra nociception of where our foot is in space, that proprioceptive feedback, because it is a really nice option. But like I'm saying, be led by the patient's symptoms there. And that's going to then come into how we're going to do this. Now, this is pretty much the same as what we've talked about previously. I think I don't need to go through that in any too much depth. I've talked about the stretching, and is it controversial, is it not? I don't think it's going to harm anything. If it's causing pain over 2 out of 10, I say probably leave it to my patients, because it's likely that we're increasing any injury around a tear in that case, and that's where I'd do some imaging to sort of exclude that where able. For myself, with having the POCUS, point of care ultrasound in room, works great, but I think, yeah, we all need to start getting those ones that connect to our phone. Yes, there's a bit of an outlay, but when we're seeing a more biomechanical load, it's a really nice thing to do. And then we go down, we've done all of this. Again, corticosteroid injection in plantar fasciitis, not enough patients go for it because it offers a really good opportunity for them to have no pain pretty much straight away. And then it's pretty well resolved and we're good from there. We can put all of our other conservative, like new shoes, maybe some strapping in the short term, maybe some orthotics for the longer term, working all that together. But really we need to then start strengthening, being a real big part, and that should probably be strengthening, because what I'm talking about there, and one of my favorite exercises is intrinsic strengthening, really important. And I simply just say to my patients, every time you put your shoes on or take them off, pick up your socks with your toes. That's all I want you to do. Go slowly, grab 2, 3, 4, flare 2, 3, 4. Much slower than what I'm saying. But that's going to be a really good thing. Repeat 3 to 5 times as tolerated. If you're cramping, stop. If it's more than 2 out of 10, stop. And that's a really nice way to sort of start getting some of that intrinsic strengthening, take the pressure off our heel, and then we can graduate to our heel raises, and like I said earlier, raising that seesaw off the ground by getting that stretching and strengthening equalised. When all of this doesn't work and we've really exhausted everything, I'm talking literally everything, maybe 2, potentially 3 steroids, that's when I may start to look towards a plantar fasciotomy, and if they have a heel spur, I'm not going to take the chance, I'm going to get rid of that as well. Now for me, I do that minimally invasive under fluoroscopy, X-ray guidance. Basically it's a 3mm incision. That incision's healed within a few days. Unfortunately, it's not a fantastic procedure because there are so many nerves in this area. Where I go is basically a really nice area, but it's still going to cause some post-op pain and inflammation, edema, swelling, etc. I now want to just have a bit of a chat about some of our other causes of heel pain, because there's quite a few, and there was a retrospective study on the causes of heel pain, 250 people in 2011 by Yi et al. And they sort of said 53% is plantar fascia, 4% is plantar fibromatosis, 2% is plantar fascia rupture. That 14.8%, so the second highest, is the fat pad atrophy, and then we've got 1% neural. I don't completely agree with that myself. I'd say 100% neural. They just forgot a few zeros because there's going to be a component there. But then we talk about, and we look at this evidence and we say, well, the tears and ruptures are very much less reported in the literature because we don't always get an ultrasound. And potentially in Australia, we're actually, over imaging because we have access to it. I love my imaging. I've got it in rooms, but I refer out quite a lot. But again, I'm seeing quite chronic pain patients, and when they've seen everyone and still don't have imaging, then it's a nice spot to start. But we sort of do think, okay, well, our athletes and then those with inflammatory conditions, where's all this sort of tying in? But let's have a bit of a look at our intrinsic foot structures and, really thinking, okay, well, they are our other causes of our foot pain. When we start doing our muscle manual tests, really, like I said earlier, that very thorough assessment of each tendon can be a really good indicator. Okay, are we looking at some flexor hallucis longus tendinopathy? Maybe it's coming through, it's very deep in the tarsal tunnel, and is that potentially causing some neural pain as well? But are these tests, well, let's start, they're not positive. We're not worried about intrinsic pathology. We're going back up to something else, or we're coming back down to some of our trigger points within our calf, within our, what might be our gastrocs, our soleus, and might be that flexor hallucis muscle belly. But if they are positive, we're considering maybe some more imaging. If there's an abnormality, we're potentially looking at some tears or ruptures. We're looking at that enthesopathy, or we're looking at that heel pad atrophy, that inflammation that we're really concerned with there as well. And I wanted to talk a little bit more about that, because this is that really, that hydraulic shock absorber for the foot. It's going to be typically, hopefully, we're all, rear foot loaders, not midfoot loaders, going to be taking that initial force as that foot's put down, taking the load. And we know that that can be of concern, particularly in our older patients where we do have some of that fat pad atrophy more commonly occurring, but that can be really worsened by conditions like rheumatoid arthritis, diabetes, potentially trauma, longer term steroid use. In particular, we see a lot of our patients, particularly those with psoriatic rheumatoid or other inflammatory conditions. This all starts being something that then becomes a really bad cycle for these patients. Those symptoms are, can overlap very, very much so with our plantar fasciitis, and we commonly see this at the same time as well. But it's typically more diffuse. It is really on that weight-bearing portion of the calcaneus, that really central heel. I'm going like this because that's pretty much what I do, and that's when the patients go, yeah, that's quite enough there, I think. And really, considering that. Now, it typically doesn't radiate forwards with this sort of heel pad inflammation or the fat pad atrophy. When we start looking at, is it plantar fasciitis or, and I'm saying or, not and or, fat pad atrophy, the medial calcaneal tuberosity is not going to be painful when it's fat pad, okay? And so we can say, great, it's both, or it's one or the other. And I think that's really nice. An ultrasound is going to show that the plantar fascia is not inflamed. It's under or around 3 millimeters, and then we start thinking about, okay, well, how are we going to manage this? Think about, those really nice deep heel cups, those 16, 18 millimeter heel cups of your orthotics, and that's basically going to be pushing the fat pad underneath. A really nice clinical way that I'm sure that we all do is a little bit of strapping going medial, posterior to lateral, really cupping it in, maybe with a low dye as well, and that's, or a stirrup, and that's going to basically push the fat pad underneath, support our heel and allow that more equal weight distribution. That's sort of the mainstay of diagnosis in my head, because we can very quickly say palpation gets better once I strap that fat pad back underneath the foot. We're in a pretty good spot there. And then longer term, we're potentially looking at those cushioning shoes and that really deep heel cupped orthoses, maybe with an aperture or the cutout of the heel. Now, one that I wanted to touch on, because I hope it's coming to Australia, but they sort of said that they aren't in the market for it at the moment, is actually a collagen injectable, which is basically a synthetic fat pad injection that goes into your heel or underneath your metatarsal heads. And it's amazing, and they have such a huge uptake in the US that they don't have enough left for Australia. Putting aside the aspect of TGA takes forever to get things approved and it costs a lot of money, it's fantastic, and pretty much all of the podiatrists over there are using it for their patients.
So it works?
It works incredibly well for about 3 to 6 months, which as a business owner, I'm like, this sounds great. But also my patients love it, and that's a big part. Now, if I was saying, they typically charge 400 to 600 American dollars. About $1,000 every 3 to 6 months is, pretty good income if you've got patients to pay it. But, there is definitely those options that are coming through, and others like it as well.
What about diabetics with their collagen production?
As in which aspect?
Could you still use that in patients with diabetes?
I don't know enough about this, okay. And so I'm not going to speak out on that. Definitely something that has been used more commonly in Australia for this one is the synthetic hyaluronic acids. And I don't like those because they just, they're like a jelly. They're exactly what we see in a ganglion, and they just disperse too quickly. For $500 for 3 mils, great if you've got it, but I don't think it's an appropriate option. You know, and with this one as well, we're talking about the ethics of saying, okay, every 3 months I need $1,000 to keep you pain-free. You know, I don't know how that sits when I can say $1,000 for an orthotic, I'll take that, thank you, and we can have another 3 to 5 years. You know, there's those sort of options around it as well. Now let's pull heel pain syndrome together a little bit there, okay? Because really heel pain syndrome is where we've got all of these together, and you can start to think, okay, from what I've presented, you've probably got a bit of an idea of how I approach heel pain syndrome, in that I do throw the kitchen sink at it. I do throw a little bit of everything because I know that's what's going to get the patient better potentially quicker. But we also need to be thinking, okay, well, is it, you know, 2, 3, 4 parts of what we're looking at? How much of a neural aspect is this? If I can just target one of those, can I reduce the pain to the point where the patient's going to be quite comfortable? And so, you know, then we go, yeah, great, let's just do that so that we're right for the moment. And I think this has just turned itself off, so I'm going to jump back to the computer and go from there. But really what we're looking at is having as much, you know, of these aspects covered as possible. We really want to be bringing all of those conditions together so that we can, you know, and making sure that we know which condition it might be so that we can treat it the most comprehensive way possible. What we're looking at there, and particularly when we're starting to come back to that neural involvement, which I really love, is, you know, starting to think about, okay, is there hypersensitivity associated with our plantar fasciitis, with our plantar fat pad inflammation or our fat pad atrophy? You know, that hypersensitivity, is that peripheral or central sensitization? You know, peripheral chemical mediated sort of peripheral concern there, whereas our central, you know, we've got the recruitment of more nerves around that broader area, causing pain as we're coming up through the spinal column to the brain where it's then perceived as pain. You know, is there direct neural entrapment? Very common. You know, Baxter's tarsal tunnel syndrome, or could there be neuropathy, whether that is, you know, from long-standing entrapment, or diabetes, you know, alcoholism, all these other things. Could it be something, and I love it, B12 deficiency? Great, let's get an injection, we're pretty much cured. We might need a few more of those throughout our life, but otherwise it's a really nice thing that we can be looking at. You know, but also, are there elements of bone edema, some bone bruising that's happening there, and pretty much all, you know, chronic plantar fasciitis that you do an MRI for is going to have that origin bone bruising that's of concern. But then we start looking further into, okay, inflammatory conditions. Like I said, that rheumatoid arthritis, the ankylosing spondylitis, you know, our patients with diabetes and neuropathy, you know, and that's going to influence, you know, the perception of pain. Or further, you know, our endocrine disorders, you know, with associated bone disease leading to higher fracture risk. All these sort of things then start coming together, and we start going, okay, we need to be looking at this in a lot more depth. You know, needless to say, heel pain syndrome is difficult, it's complex. We want to be looking at this with as much depth as possible because it's not going to be straightforward. And our typical presentations, as you well know, they're coming in with those multiple aspects of pain. You know, there is no time of the day that they're really comfortable. It's pretty constant from, you know, coming out of bed to going to bed, but it does change on activity. You know, it sort of has that period in the middle where they go, oh, it's awful for a few steps, and then it warms up, and then about 10, 15 minutes later it gets worse again. And you're saying, well, that doesn't sound like plantar fasciitis, you know, that warms up and gets better. You know, maybe there's a bit of bony component. Maybe that fat pad atrophy's coming. You know, actually there's a little bit of burning that's coming on as well the more they exercise, or when they put their foot in this weird position. And then we start going, okay, well, there's a bit more neural component. Typically these patients, for me definitely, they've seen multiple practitioners. They're sort of coming to you thinking, okay, there's got to be something more here, or I want surgery. They're not sure what surgery, and I go, I'm not sure what surgery. We just need to exhaust the conservative maybe more appropriately, or put things into place that aren't typical, like some of those injections that we undertake. You know, it's definitely typically a longer term pain, because when we have things that are inflamed for a longer period of time, and we see this a lot in that peripheral sensitization where everything becomes inflamed, there's a lot of chemical sort of, you know, that chemical mediated pain, we need to start looking, okay, well, there are other structures that are now been put out. We've changed how we're moving. That gait change is now overloading more of that lateral and changing how we're looking. And for me, they come through and they've got, you know, their plastic sleeve with all their imaging reports and all the letters from their other doctors, and I go, cool, let me just take 10 minutes and go through all these pull-up imaging. Okay, everything's, you know, 2-3 years old, great. You know, what have we had recently? Is there a more appropriate option or thing? And, you know, then you do the assessment and you go, oh, this is actually pretty straightforward. It's just that you got 3 or 4 things and maybe they haven't been managed collectively to the most appropriate way. Now for me, that comes in, my recipe as such when it comes to sort of chronic heel pain, you know, it's similar to what I've already covered, obviously. You know, a little bit of rest is great. Some anti-inflammatories, even if they just start on a 5-day course of ibuprofen, we can get it from Woolies, great. You know, again, checking out those with asthma, checking out those with any reflux or, you know, concerns there with the stomach. But really be aggressive, you know, do consider whether there's a steroid injection needed. I've got one lady at the moment that's actually got a real true plantar heel pain syndrome of the right foot, but then just has some really bad peroneal brevis pain of the other foot because of the overload onto that foot. And so you then start thinking, okay, well, I've recommended steroid for the right and I've recommended prolotherapy for the left. At the same time, we're looking towards orthotics. We're doing laser therapy, 2 different protocols for each foot. You know, do think whether you want the shockwave therapy. And for me, I don't do as much shockwave and stretching. You know, I very rarely use my shockwave at the moment. I'd say for people that don't respond to my normal recipe. But really, you know, if it's not cutting through, then we need to start thinking about this. Definitely the orthotics, the strapping, during pretty much every musculoskeletal consult that I do, getting rid of all my bunions and hamatoes in surgical patients, or traditional sort of, you know, surgical patients, I'm typically going to load their foot in a different way with either some semi-compressible felt or, like I mentioned earlier, that Hyperfix. I do really love changing patients' mechanics, and most of the time they'll get up and they'll say 50 to 70% better already, and they'll look at you like this and you go, great, I'm on the right track. That confirms what I'm looking at. And that's really rewarding, as we all know as well. There's not many professions where you can have a patient walk in and then walk out in less pain. We always say that for ingrown toenails, it's pretty much the only thing that people can come in and then walk out with no pain. And so it's similar in this way, that we're significantly reducing their pain. Now for me, I'm the LiftDoc prolotherapy, the 5% dextrose, I do a lot of this. At sort of my peak, I would be doing sort of 3, 4, even 5 different patients in one day. At the moment, you know, a little bit less, but it's something, and you know, I did yesterday very successfully, to the point that the patient came back in today just to tell me that she's had a 70% reduction in her pain. Now this is a patient that didn't want these injections straight away. And so she came back in knowing that she'd exhausted everything, really deflated, sort of thinking that she's going to have to put off a holiday coming up in June. And I'm like, no, let's just try this. Our last shot, she walked out in 50% less pain and then came back in 70% less pain, you know, since, you know, today, you know, 24 hours later. And I think that's a really good thing. Definitely for the podiatrists in the room, we do have a course next weekend on the LiftDoc prolotherapy as well. There's some QR codes around if you do want to have a bit of a look at that, or come and have a chat to me. It is a really good option for a lot of different things, but I typically find in heel pain, particularly those burning neural sort of ones, we can free that up quite nicely. I typically like to avoid cam walkers in the first instance, and that's in our sort of plantar heel pain syndrome, and I take this from a nervy point of way perspective. Anything that is starting to scream to me, you know, nerve pain syndrome, I'm like, nah, I'm not happy here. I don't want to isolate, I don't want to offload. I want to make sure that I keep this moving and massage and really get it going. Now, not always is that able to be done, particularly if we've got a strong osseous component, but typically I'll try to get people moving through what they're looking at when it comes to, you know, particularly burning pain and neural pain. When it's quite sharp, I'd rather sort of change a lot of their loading and how they're loading through the foot rather than completely stop that loading. The other aspect there is surgery. I avoid surgery in patients that have got nervy pain. I have had, one or two instances previously where I just go, we need to get rid of the nervy pain first. And once we've got just a true plantar fasciitis, if it's still not resolving, then I might look at something. But really, there's quite a few things that we can do to get rid of these nerve sensitivities. And that's, what I concentrate on doing, desensitizing the nerves, decrease our inflammation. Let's change how they're loading, change the gait. Let's get some strengthening. We talked about the intrinsics, the heel raises. We talk about the strapping, the taping. And I basically put this onto, a one piece of paper, double-sided, in that front sheet, and I'm happy to give that to those that are here tonight, that basically says this is all your conservative with regards to stretching, strengthening devices, footwear characteristics, socks, using arches, for instance, around home. And then the back page is all your orthotics, your shockwave, your laser therapy, your injection therapies, and then we go into our surgery. And I sort of say the front page is all the free things. If you don't want to come see me again, do those. Back page is if you want to be aggressive, I'm your man. Here it is, and these are the costs around it. And I think that's a really nice way where patients can go, yeah, great, I know what I can do. And a lot of patients will go home, have a bit of a think about that and say, yeah, cool, let's look towards this, that, not this, let's do that.
So do
And that's nice.
start with the easy stuff?
I am very lucky that I see patients that have had pain for quite a while and have tried a lot of everything else.
So they want to go to apps.
They usually go everything I highlight on the front page, and that's literally what I do. I highlight everything that I need on the front page, and then on the back page they'll say, I only want to do the laser therapy because I'm a chicken and don't want injections. Go, great, let's talk about that in 3 sessions time if we don't resolve our pain. But yeah, some people just say, okay, I only want orthotics. We do our first session of laser therapy for free here. And so, that's always a nice one. I say, come try it, have a bit of a chat to Erin. She'll sort of go through it all and make sure that you're comfortable in what we're doing and why we're doing it. And she obviously knows our whole sort of, what we're doing, why we're doing it, and is a previous patient. That's how I found her. So she gets it and has experienced it all as well. And so that's really beneficial for patients, from a non-practitioner point of view. She's just an allied health assistant. I don't say just, but she's come from a great paramedicine background. And so really able to sort of expand that further, which is a nice way to go. Yeah. I do have the option for my patients of a program where it's basically they have 10 sessions of the laser, they have 8 sessions with me, which can include or doesn't include the injections, but the price is all within it. And then they get custom orthotics as well, just for a set price, and it's about $1,500 off if they paid as they go. Because I'm like, let's throw the kitchen sink at it. I would like to incentivize my patients to do so. And I'm very happy when I don't have to talk about money with my patients as well. I do it all up front, and on this sheet, all what I would otherwise charge is on there as well. So I think it's just a really nice sort of financial consent. Here's your plan. This is the free stuff. This is what you've got to pay for. And it's all there. So, and I'm happy to grab those so that you got a bit of an idea of what I'm looking at, because I think it really does take a comprehensive approach. As we all know, these patients don't always get the best outcome. And then, I do see for those that do laser therapy, not always do they need the prolotherapy. Those that do prolotherapy, I find do better when they have the laser therapy just before rather than afterwards, or not at all, because really we're loosening everything up and then we're desensitizing the nerves. And so there's all these different aspects of what we're looking at there too. I think we've pretty much made it. Thank you, everyone. We've got our learning management system coming online, and I've been playing around with it again today as I get the prolotherapy course up. It's fantastic. It's going to have a whole heap of content for free, but also some paid subscription-based courses and further education. We do have our monthly seminars, and I already said about the toes, taming the toes, managing corns and other toe conditions. Those interdigital corns, those subungual hematomas, as well as our osseous concerns there, osteochondromas, that whole side of things as well. For those that are interested, there's definitely QR codes on the way out that way. And I'm looking at this from a podiatrist point of view, which